Welcome everyone to Playing with Perspectives. I am Ryan Malphrus. I am a clinical social worker that has been in the field for about 15 years, and I enjoy playing with ideas. And so I wanted to first, before diving into this, talk a little bit about my approach to exploring different ideas that may be uncomfortable, difficult, interesting, and any of those things of the above. So my first idea that I am always thinking about is I am pragmatic. I want things to work. I want things to be useful. I became a clinician because I wanted to actually help people. I find all the theory very interesting and very enjoyable to think about why I am the way that I am. But try to make a dividing line between the interesting aspect of why we are the way that we are, and what my job is to help people change or get healthier or do something different about their lives. And this idea today that we're going to be talking about is, cuts to the core of this is that sometimes the why maybe needs to be decoupled from how we alter someone's life in the therapeutic environment. So another idea that I always am thinking about when I am exploring these ideas is that I am not a team guy the way that I think about it. I am not an elite. I have no allegiance to the psychoanalytic theory, to CBT, to self-psychology, or any of these fields. I think they are all have something useful that we could be using to help our clients, and then every client might need something different. So one of the reasons that I'm always looking around for different things is that I think the more tools I can have in my tool belt, the better that I am able to give out services to people. I think an interesting idea here. So one of the ideas that I'm often thinking about is how similar all the various theories are. There's often, it feels like after you've read enough of these books that these stories, metaphors are just that author's attempt to understand human behavior and the mechanisms in which those behaviors are changed or altered in some way. And if you read enough of this, they start kind of coming together. And so another one of my goals is to unify things, to see even things that maybe on paper are set apart from one another, how the threads can be kind of brought together. What are things that are similarities, and how we can connect these things. Um, so, given this idea that I'm not a team guy, I don't care if they criticize the theory that I like, because I have changed my mind 1,000 times throughout my career. I've been doing this for about 15 years now, and I can't tell you how many pretty significant transformations I have made in my thinking of why people act the way that they do, as well as how I interact with them in the process of helping them change. So, in the book that we're talking about today is this book here, Reality Therapy by William Glasser. I'm going to give some examples of why I really like this book, but I'm going to start off with some things that were uncomfortable about this book, and one of the to tie it to my approach of how I try to deal with these things. So, the first idea is if you read this book, this book was written in the 1960s. And one of the key points that he brings up repeatedly is that psychiatric treatment of ulcers. Now, in the 60s, we thought ulcers were a psychosomatic issue, that it was based upon stress and those factors, and they were treated through psychological means. We have since figured out, well, that was just wrong. So you read this book, you're like, oh, he is clearly just incorrect about this. We have now learned that you just need some antibiotics and there's, bacterial infection. I'm a doctor, so I might have that kind of wrong, but that's the general idea. He's wrong. I don't think that negates the rest of what he writes in this book. I think there's a lot of really interesting, challenging ideas. So that's the first thought, is that whenever you're reading something, you may vehemently disagree with something or see that like they were just wrong about something. It doesn't mean you can throw at everything. So one thing I'm trying to do is recognize, hey, this was an example in which he was just wrong about this, clearly. And okay, what else? Is there something else that I can kind of ignore this and understand this was either a product of the time, or maybe they're just ignorant about something, and that's okay. The next thing that this book does is really challenge you with the conventions of now. So, and what I mean by that is that his book is challenging how we are currently doing things. And again, this is a bit of a time and a place issue. So, the example in this, there's a section of this book that talks about the treatment of homosexuality. So, if you know about the history of psychology, is that homosexuality was considered a mental disorder that was in the DSM, and thus something that is warranted of thought of how do we help people treat this thing. Very uncomfortable to read, let me tell you. I read this and I was like, whew, I'm not really sure how I feel about this and how this is handled. Again, I wanted to dig through it, and as I got to it, this is not as horrible as I thought initially of, oh, they're treating these people as deranged or ill in some way. It was actually handled with quite a bit of compassion, but they thought about the problem differently then. And that's something that I think, in my eyes, is okay. They lived in a different time and a different place. And so when I'm taking, whether it is these ideas from the 1960s or maybe a book that's even older than this, they're going to have different language with different ideas. And my goal is to go play with that for a second. It doesn't mean I'm going to adopt every idea that they have, but I'm going to take what I think is useful and what I can then use to then help the people that I am working with and now to disseminate to you all the ideas that might be useful to you all. So that is kind of the theme or the idea of what we are doing here. So without further ado, we are going to get into what I'm going to call my book yapping about reality therapy by Dr. William Glasser. And I'm going to try to make this as succinct as possible. One of my goals here is to make, you don't need to read the book. I'm going to try to give you as close as I can, but these are my interpretations of what he wrote. So if you have ideas that are different than mine, let me know. You maybe have a better idea or more spot on. Maybe I misinterpreted something. All I can give is my perspective on what I read and what I think is interesting. And that's what we're going to talk about today. So without further ado, the first idea is what is being treated in reality therapy. This is a thing that he goes over in quite a great detail. And he breaks it down very simply. He says, other psychiatric disorders and treatments are dealing with illness. And what Dr. William Glasser does is says, okay, these illnesses are real, people are suffering, but what he is doing is going like one layer above and saying, well, all of these illnesses are different categories of what he calls irresponsibility. And what this really means is these people are unable to meet their needs. That is at the base of this is as when people are mentally ill, they are finding some alternative ways to meet their needs that is not working so well for them, essentially. And that what we're doing in our current mental health system is that we are categorizing these into little boxes. But if we look at it, all of this is a failure to meet your needs in a way that is productive. I think it's a really interesting idea. And rather than pathologizing what is wrong with someone, we are looking this through a needs fulfillment and that they're doing their best in that moment to meet their needs. So there's no, hey, you're being immoral. It's just this is how you're doing this, and there's going to be consequences to the different ways that we meet our needs. So when we talk about needs, what are we even talking about? So according to Dr. William Glasser, he has two needs that really kind of break down into maybe like three or four. But the way he describes this is quoted from him, is the need to love and be loved, and the need to feel that we are worthwhile to ourselves and others. And this is an interesting thing that is like, okay, this is, again, above all of the things that we do in our lives. These are the kind of drives that are driving us. So you may not agree with these different things, but for the perspective of we're going to play with these ideas, we're going to take this for granted. This is it. This is what people are trying to do. And so one of the ways that he kind of describes these things is to get a bit deeper into this idea of to be loved and be loved and to feel worthwhile. And he saw these as kind of interchangeable ideas, is that if someone is able to love others and to receive love, they're also probably a worthwhile person. And there's some deviations to that where it's not always true, but he also saw these as quite interchangeable things. In that often these symptoms of, say, depression are a recognition that we are not living up to our needs to feel worthwhile. So we're not doing the things that we ourselves as the individual are judging as worthwhile. And because of that, we are not either getting and receiving love from others, and we aren't able to give to others. And that these are the main psychological problems that we have. This is a very broad idea, but it's interesting to see how we could maybe apply this to the various mental disorders that we see and think about in our current day in life. So then he goes on to talk about, okay, so we have these needs. Well, how do we meet them? What is the purpose of either life or in this book, what is the role of therapeutic treatment? So he has a foundational aspect of this, and there are two kind of main ideas. And I'm going to go over the first one, which is called involvement. And so Dr. William Glasser said, I think the quote of his is that briefly, we must be involved with other people, one at a minimum, but hopefully many more than one. I was first introduced to Dr. Glasser actually when I trained a therapeutic de-escalation program, and his ideas were, in this exact quote, I believe, is what was brought up. And I was working in a school with children with severe emotional and behavioral disorders, and this was something that we came across quite often, is that there was not a single responsible adult that did what they needed to do to demonstrate, not to say, but to demonstrate that they cared about the other person, that child. And so Dr. William Glasser, I believe correctly has identified we need other people. And at the very least, we need one other person. I think that, to me personally, says to me that is the role that often clinicians play, is that unfortunately in many people's lives, there's not another adult that's going to sit with them for maybe as long as it takes to take seriously the challenges and issues that they're going on in their lives. And that is a huge role that I think myself as a clinician often am playing, is that I'm not special. I'm not doing any magical words, but I am a person that cares about the person that's sitting in front of me and willing to give them everything that I have for that 50-minute session that I am meeting with them in for, to help them understand themselves. But part of that is I have to care about them. This can't be like I'm doing a job, I'm typing on my computer like while you're talking to get my notes done. I have to genuinely be involved. And so this deeper meaning to me was meaning to Dr. Glasser was that it's not just this faux I'm showing up to my job. I actually have to allow my clients to matter to me, so that when they succeed and fail, I feel something. I cannot be so detached. And this is one of his critiques of conventional therapy, historically, was the amount of detachment from the therapist. Is your idea of being a blank slate to allow transference to occur. The idea that transference is the idea that you are feeling feelings that are not associated with the person that's in front of you, but a historical figure in your life, and you are putting that onto the person that you are currently talking to. And so he thinks very differently and says, no, that's not my goal here. My goal is to actually demonstrate to someone that they can become emotionally involved with someone that cares about them. But the important thing is that the person that I'm working with, they have to be convinced that I care about them. It can't just be me in my head thinking I care about them. I have to convince the other person that I care about them. And that's an interesting thing right there. Am I convincing them bullish, like in a deceptive way, in a manipulative way to get them to do something differently? Or do I actually take it seriously that maybe this person has been let down in their lives 10, 20, 100 different times throughout their lives, and it might just take some time for them to trust me and feel that I actually do care about them, because they've never experienced that at all in their life. I very often confront this when engaged in individual therapy, is that I tell everyone the first session they meet with me is that you don't trust me right now, and you shouldn't. And if you do, I'm questioning how much you really understand what trust is. And now I might not say that harshly, but that's kind of what I'm thinking, is that I'm a new person to you. Yes, I am paid, I have a license, I am responsible for performing this job, but you don't know me. I may let you down like maybe the 4 other therapists that you've met and they didn't help you. It's not an uncommon experience for people to have, is to go seek treatment by someone that is deemed through some special degree or license to actually be helpful, and then for them to not help you, or sadly sometimes make it worse. And so part of my job is not only to demonstrate and to actually care, but I have to demonstrate that through action. And to me, words are never enough. I can tell someone, yeah, I care about you, blah, blah, blah. What often people are looking for is like, well, when I'm at my worst and I am, let's say if someone has anger problems and I am enraged at something that I have said as a clinician, what are you going to do? Are you going to abandon me like everyone else? Are you going to punch me back? Or are you going to take seriously my rage and maybe consider that there's something else going on? So involvement is this really deep idea. It's just very similar to this idea of rapport that is often talked about in counseling, but it's talked about a bit differently with Glasser, is that he expects the clinician to actually become more human around the client. So in traditional therapy, often we don't talk about persons. Talk about the self-disclosure is usually frowned upon, and if used very sparingly. And Dr. William Glasser takes a different approach. He says, no, the therapist actually has to demonstrate that they are a human, that they're also struggling through very similar issues, and that they're willing to show that they are fallible just like the client is, and that they are in this kind of essentially journey throughout life together. And it's a very important aspect of this. So that leads into the next, general idea. So once we have involvement with another person, that is like this foundational thing that therapy cannot proceed without that. Once you have that, the main idea that Dr. William Glasser is looking at is responsibility. And so we're going to have to take our idea of responsibility, and it's something you might hear me talk about a lot. We have our own definitions of almost every word. You have a definition of responsibility. Whoever you are that's taking their time, thank you so much for listening to this, and hit that subscribe button for me. For you that are listening to this, you have your own definition of what that word responsibility means. It's different than mine. It's different than Dr. Glasser's. And so what we're going to do today is I'm going to read you Dr. Glasser's example and definition of responsibility, and that is what we're going to use because we're going to talk past each other otherwise. So his definition of this is that it is one's ability to fulfill one's needs and do so in a way that does not deprive others of the ability to fulfill their needs. So again, this goes in line with, well, Our goal as a clinician is to help other people meet their needs when they're failing to do so. But again, the big thing here is that we are not allowed to meet our needs by the deprivation of someone else's needs. So he gives an example of this. I think highlights it really well. And so he gives an example of, let's say that we'll use me as an example. I am going about my life and I realize that there's a girl and that is fallen in love with me. And I have a choice to make. She lets me know this in some way that I am someone that she's interested in and that she would like to date. And to Dr. William Glasser's, well, to be a responsible man, what I would do if my feelings are reciprocal, well, then I tell her that and everything's wonderful. If they're not reciprocal, the responsible thing to do is to tell her, hey, I'm so sorry that my feelings are not the same as yours. I just want to let you know this so you can then go fulfill your needs of love somewhere else. And what he would say is that a typical example of male irresponsibility would be to get my sexual or material needs met through this relationship when I don't really feel that strong feeling of love towards her, knowing that I'm going to maybe get my needs met, great, but I am taking away someone else's ability to meet their needs. So that's this idea of responsibility, is that often when we are engaging in some type of behavior, usually it's like, hey, I want something. I want to eat something. So I get the feeling of hunger to go away. And usually, great, there's nothing wrong with this. But there are certain behaviors that we do that in which we are recruiting other people to deal with our stuff, and that it takes away their ability to then go deal with their stuff. So I was thinking of an example of this. If we think of the traditional mental health disorders, someone that is depressed is trying to meet their needs through Dr. William Glasser's ideas through various means of, well, if I act a certain way and I'm like this, people start to change around you. And this is, again, from my experience, a very true statement that if someone is behaving a certain way, especially in a way that we deem as, pathological in some way in our current mindsets, that we're going to give them care. That's how this works, is that, if someone is struggling, there's a human, it seems like just natural thing that I want to be caring towards this person. And it's going to change. And it's eventually that can really start costing these other people something real, that their so much time and effort is now caring for me that they are not able to fulfill their own needs. And this is something that I witness quite often. The idea of resentment is always an idea that's big in my mind. And this is an example of that is, after a while, when someone starts caring for you so much that they start neglecting their own needs, to me, a feeling that often comes up is resentment. And that's usually pretty toxic for a relationship. So this idea that I want to make sure that I'm meeting my needs, but be quite cautious to make sure that I'm not impeding someone else to do that. And so that's one of these interesting ideas of saying, okay, there's nothing wrong with you. So this is to go into the next idea that I think is the real provocative idea. So everything I think he's said so far, yeah, I mean, I feel like you could slot this into a lot of other conventional psychiatry, psychology, therapy, and those types of things. But the next thing he says is that there's no such thing as mental illness. I think that's a pretty fun statement. It's provocative. And I want to try to clarify my interpretation and understanding of it, of what he is talking about, is that it's not that people aren't suffering for very specific reasons. He actually doesn't negate at all, especially the psychoanalytic tradition of why we are suffering the way that we are. It seems to be, to me, that he agrees and takes real no issue with those statements. But what he is saying is that in the treatment of these challenges for him, what he would say is irresponsibilities, that why these things have occurred don't actually matter. And that's the real provocative thing, is we're often told to validate everyone's feelings and that we have to respect them. And what Dr. William Glasser says, no. And his idea behind this is that when you tell someone that they're sick, use the word illness, is that you go to someone else to get cured of an illness. It's just like this bad external thing that has happened to you that you have very little control over. You think of cancer, you didn't do anything often for cancer, and like the way to deal with it is not like changing your mindset, is you have to go to the doctor and that's to do something to you to cure this. There's a biological dysfunction. And what I think Dr. Glasser was seemingly correct about is that, in the wonderful year of 2026 of right now, we have still really failed to find biological markers for these discrete categories that we tend to use. And so what he's saying is that, okay, what if that, all these categories that we have deemed as mental illness, you take one step above that, and really it's just a bunch of people being irresponsible. Again, remember his definition is irresponsibility is that these people are not fulfilling their needs in ways that impede other people's access to meet their needs. And so looking at it, it doesn't matter if the person is schizophrenic, if they're depressed, if they're anxious, or why these things occurred. I'm not really interested in that in the treatment of this. And I think that's an interesting idea. And so one of his contentions is that by delving into the why and the history and going into our past is that we, one, can get into this trap of figuring out this thought that I think has, in my opinion, is a bit outdated. So again, this book was written in the 1960s. So nowadays, I don't think psychoanalytic practitioners would say uncovering the insight is it, and that catharsis is what we're going for. I think that we have moved past this. But Dr. William Glasser is really pushing on this idea that it doesn't matter, because let's say you knew every little bit of why. This doesn't actually help you in your relationship now with your wife currently if you knew exactly why your mother's treatment of you made you into the person that you are today. And what he is claiming is that this is all a distraction from the things that you need to be doing now. And that, yes, sure, all these things are true, that your trauma is real, it happened, and it left a lasting impact on you. But my job as a clinician, according to Dr. Glasser, is what do I do to help you live a better life now? And talking about mom or dad or traumatic events in the past does nothing but, one, distract you, and two, disempowers you to say that what can you do to solve your problems now? Where you say, if you take a sick role, well, I'm not expecting a lot out of you. You're sick. If someone has cancer, I'm not expecting them to go run a marathon. You're expecting them to be sick, and other people will treat you that way. And Dr. William Glass says, no, 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 no. You're not sick. You're engaging in a bunch of different behaviors that are not fulfilling your needs, and you can do something about that. And what his idea of the role of the clinician is to not allow the client to escape reality, is why it's called reality therapy, is that the reality is, hey, you're not meeting your needs, and no one's coming to save the day. And no amount of us talking about your past, about why something occurring, is going to alter the problem that you're dealing with in the here and now. And so Dr. William Glasser was really focused on the here and now, and something that I really agreed with. It was something I really appreciated about the book, is that I love psychoanalytic thought. I think it's fascinating. I think it does an excellent job explaining why people are the way they are. I've always struggled as a clinician to figure out, all right, how do I get from, we have a conceptualization of why something is happening, the how we change it and what we do to help someone change it has been a lot less clear to me. And so I think this is a very pragmatic approach to this, is saying that we don't have to do some alterations where I fix the bad mother figure in your life and then I give you a corrective emotional experience, which is, there's a bit of woo there where I'm not exactly sure, as a very pragmatic person, how do I do that reliably? How do I know that I'm doing this? What is the effectiveness of this? It's confusing for me personally, and maybe I'm stupid, and maybe other people can correct me in the comments of how they approach this in a very pragmatic way. I would love to hear it, but I have not figured that out. So this is something that I actually, in my experience working with students in a school setting, which is where Dr. William Glasser actually developed a lot of these ideas, I found to be oh, this actually mimics a lot of how I practice with people. Is I worked with people with the diagnosis of ODD, or oppositional defiant disorder. There's a lot of feelings about this disorder. I don't think it's a real disorder. I think it is a lot of people have jokingly called this bad parenting disorder, because often this is a child who has not been given firm boundaries at home, or has not been loved at home and neglected. There's going to be a lot of home issues that are going on. And when they come into an environment like a school where authority is trying to get you to do things, they don't deal with it well because their authority figures in their life have been dysfunctional. And so does that child have a mental disorder, or is their environment and systems that they're a part of dysfunctional in themselves? And so when I worked with these kids, oftentimes they would get this classification of, you have ODD, or you have oppositional defiant disorder. And a bunch of things happen. When you have that label, people start looking at you and treating you differently. They don't expect a lot of it. You're an ODD kid. Why? You're in a special ed school. These kids aren't going to become doctors and lawyers. It's just not, they're not going to do that, because they're this type of illness that they have is going to prevent them from doing these things. Now, I often wouldn't take this approach and say, okay, again, the problems are real. The suffering that someone is incurring is real. But what's the actual problem? Do they have an illness, or is there something more going on? And can I actually encourage them to take control of these things to the best of their ability? And this is an uncomfortable idea. I get a lot of pushback for this idea, is that it feels unfair. There's a child you have here, and they are being, let's say they're being, take it seriously, they're being abused, legitimately abused by their parents. And you as a clinician are telling that child, it's your responsibility to be more responsible. And there's something that feels extraordinarily unfair about that. And I understand. I'm not saying it's their fault that these things are happening. My role as a clinician, though, is to help someone, no matter the situation, no matter the system that they are found themselves in, is that I only have that person sitting in front of me to alter. I can't go and change their family if their family's not willing to come in and talk to me. I can't go change the justice system. I can't change the political reality or the cultural reality of our world. But what we can do in this individual one-on-one thing that we're doing here is analyze how you are interacting with these systems, and are there ways that you could interact with them in a more effective way so you can get your needs fulfilled. Is that fair? No, it's not. Life is not fair, and I've never told anyone that I've worked with that it is. I think that's a crazy idea to expect that that life is fair and we get treated like we think we should be treated. Um, and so the idea behind this is not to minimize, blame, or do any of that, but it's to take a real consideration of like, hey, my hands are kind of tied as the clinician. I would love to wave my magic wand and have your mom or dad treat you better. I would love for society to look at you in a neutral way rather than having a negative valence towards you. I don't have the power to do that. What I can help you with is, in the time I have to spend with you, sit down and listen the best I can to try to understand that the problems that are happening, and look at the things that you actually can change and be realistic with you about what those are. And not to say that you're going to change into a radically different person, but I've never met someone that is not making their life worse. And I include myself in this. So there's things that I have had that have been legitimately difficult and are not my fault. And I've also contributed to making it worse. An analogy that I often use in this, that I've used often with clients, is that, using the psychoanalytic ideas, I think absolutely like our parents are carrying a baton, we're running a relay race, and they hand that baton off to us. And what we often do, we just keep running. And at no point do we stop and someone be like, hey, you can just drop that. Like you don't have to run the race anymore. Like I know it got handed to you and like you didn't really realize what was happening. You don't have to do that anymore. And there's a way that you could act that might benefit you according to what you're telling me you want. This is not me telling someone to behave better so that they function in the system better and the system has less friction. I don't give a shit about the system's friction. But if someone's telling me I hate this and I want this and I'm not able to get it, well, we might be able to look at, hey, you're doing this thing and like it seems like it's not really getting you the thing that you want. What are alternative ways of interacting or engaging that could get you what you want? A phrase that I've often used when I worked with adolescents was, when I was trying to convince them that I was someone that actually cared about them, was like, hey, my job is to help you get what you want in life. And that's it. And I think that really is my role, is like someone's going to tell me. Everyone has different kind of flavors of needs of that, those love and feeling worthwhile, and how they want to meet those needs can be very individualistic. I'm often listening to them saying, okay, cool. You want to meet it through this way? Great. That's yours. Great. How do I help you get there? And Dr. William Glasser's ideas, I think, here can actually be really useful for a lot of clinicians. That I think often we have, there's a lot of critique of clinicians that we have gone too far away from confrontation, too deeply into validating. And I think that's where this idea is interesting to play around with is, are there times in which I am uncomfortable confronting someone? But it's hard. This talks about in the book is that when you confront someone with an issue that is very true and that they need to work on, oftentimes they get really mad at you. They don't want to deal with it. And fair enough. Maybe they didn't ask you. Many people online have talked about, being a therapist to your friends is not a good way to be a friend. It is frustrating because I am having you confront something often that you have been avoiding, not even consciously, maybe your entire life. So having the ability to confront people with reality and say, hey, you know what? I know this other person mistreated you. I hear you. I don't think how you reacted actually got you what you wanted. And let's talk about that. And is there another way you can deal with that? Even though I know it's not fair that this person's treating you this way. Again, for me, the pragmatic aspect of this is I have no control over this other person and changing them. They're not coming into my office. So I can only help the thing that I can control. So I'm going to sum this up here because I think this is the general idea of this, and how I like to play with this idea is, how do I utilize this when working with someone? Understanding my limitations as a clinician is that I'm not God. I'm not a magical wizard that can change all these things. I have a very limited role and a very limited ability to change things. And it's usually that person that's sitting in front of me, not anybody else, and getting them to be able to meet their needs in a better way that is not impeding on the needs of others, because that ends up isolating themselves and they lose out on their feelings of love. They don't feel worthwhile because they're not behaving in a way that they themselves feel good about. So this is an example of some of these ideas that I think are fascinating. And I love going back into the 1960s, where some weird and uncomfortable stuff going on there. But I think there's a lot of really interesting things that you can apply to your current day thinking practices. And so I would love to hear, other people's ideas of how, when they hear that feeling of people need to be more responsible or that they're irresponsible, it elicits a lot of intense emotions. But if we can, again, play with this idea of his definition of this and how he intends to use it, I think there's a lot of really good stuff here that we could help us be better clinicians, better people, and some really cool ideas. Again, just have fun, see something that's interesting, something different. So thank you for coming along and playing along with me today, looking at some ideas out of reality therapy, and I hope to catch you next time.